So welcome and thank you for joining us. My name is Karen Corman and I have the privilege of being the Executive Director of the UIC Alumni Association. Welcome to the UIC Alumni Exchange Series. Today is our 25th program for UIC Alumni Exchange since we began this series in April. Each week, we work to bring you a variety of programs and topics so you can explore, connect, and even escape from the everyday with a community of UIC alumni, faculty, and staff experts. You'll hear me say this a few times today, but I encourage you to visit go.uic.edu/alumni exchange for the latest and greatest programming. And with that, I'm excited to start our program this afternoon featuring Dr. Ron Hershow, who is the Director of the Division of Epidemiology and Biostatistics at the UIC School of Public Health. Dr. Hershow has been involved with COVID-19 research and contact tracing in Chicago communities and on our UIC campus. We are grateful he has joined us today to talk about where we are and where we are going in the fight against COVID-19. Thank you, Dr. Hershow, for being with us, and I'll turn it over to you to begin the program.
Thank you so much for that nice introduction and for the invitation to speak today. And thank you, audience, for joining us today. I had a preview of the list and I saw many old friends on the list, and I have been at the school for about 33 years, so it was heartening to see the list populate with a lot of my old friends. So I want to welcome you to the talk, and today I will be talking to you about the COVID-19 pandemic that is afflicting our world. Preparing this talk has afforded me the opportunity to reflect not only on the current pandemic, but also on my career. My professional life as an infectious disease epidemiologist and clinician has been bracketed by the two great pandemics of our time, the HIV/AIDS pandemic and the current COVID-19 pandemic. Though combating these diseases has of course been challenging and stressful, they have also been endlessly fascinating and have reminded me every day of why I chose to go into infectious diseases and public health. In this lecture, I will cast my eyes back to the very beginning of the COVID-19 pandemic, and then focus on specific aspects of COVID-19 that exemplify our continuous struggle to understand this awful disease. We have seen an explosion of knowledge regarding this disease, but there's still much to learn. And by focusing on specific issues, I will attempt to capture our still evolving understanding of this disease and our dynamic attempts to control this pandemic. So I might as well start at the beginning. This is, of course, a map of China, and I was actually teaching my course in the spring semester. This was in January, and this is a course on terrorism as a public health issue. And in this course that's really on terrorism, we make the point that nature is the best terrorist, and that nature always has surprises in store for us in the form of emerging health issues and infectious diseases. And then in January, I started to read reports of this new coronavirus that was spreading in central China, in the city of Wuhan. And I remember calling it to the class's attention and even inviting a lecturer in to speak about it, who was a Chinese national named Zhifang Zhu. Having some issues with my slide advance. In any event, when we had that first lecture on what we then called the Wuhan epidemic, we highlighted a recent study that had been in the Lancet of the first 99 cases of this new disease. And what was interesting about this report in part was that it showed that these 99, about half of them had a history of exposure to a specific seafood market in the city. And what we postulate is that this is a zoonotic infection. Coronaviruses like to live in bat species as their host reservoir, but bats can then infect other animals that might be important in the ongoing transmission to humans. And what we estimate must have happened is a species jump from some food item that was being sold in this market led to the acquisition of this disease in the first human case. What's interesting looking back at this first publication is how right on the symptom identification was. All of these symptoms that were noted to be manifestations in these first 99 patients, of course, are still symptoms, but as we've learned more about this disease, we've of course realized that this is a multi-system disease with many, many more symptoms than we first envisioned when this report came out. From that first report, and during that class that I was teaching, I in the class observed the disease spread throughout China, and then its progression across the rest of the world, and that's exemplified in part C of this picture. And we can all remember, I think, when the disease made landfall in America, the early Seattle outbreak. And then soon after that, we realized the disease was also spreading to New York from Europe. And of course, if we then fast forward to a recent dashboard picture on the WHO's website, we can see that what has happened in the 9 months that has ensued since then. As soon as you make a slide like this, it's obsolete. And when I made it, there were 985,000 global deaths from this disease. But a few days ago, we passed another grim milestone for this disease with over 1 million deaths. And what you can also see on this figure is that although the disease started in Asia, the Western Hemisphere has played a prominent role in case occurrence and case incidence. If we now focus on the US epidemic, we've just recently reached some key milestones for our country as well. We've surpassed 7 million cases and we've surpassed 200,000 deaths. And to put our American experience in some perspective, although the US has only 4% of the world's population, we have fully 22% of COVID-19 related deaths in our country. And it must be acknowledged that this story represents a vast and tragic public health failure. One thing, I guess a theme of this talk is the idea of how our understanding has changed over time, or how certain facets of the disease have come into clearer focus. The one thing that's been consistent since the beginning in the US epidemic is the issue of health inequalities with this disease. And what we now have large amounts of evidence to support is that our African American, Latinx, and American Indian populations are bearing a disproportionate burden of incidence and hospitalization and death. For example, these populations experience rates of hospitalization for COVID that are 4.5 to 5.5 times higher than whites. And it was this reality, this stark reality, that makes our School of Public Health so excited right now to partner with Chicago community-based organizations and other partners to hire and train an expanded contact tracing workforce to assist in Chicago Department of Public Health's contact tracing efforts. In fact, the School of Public Health and other partners received a $56 million grant to fund this effort, a program that will allow us to combat these health disparities through community outreach and education. And We are just sort of launching this program now. It's a very exciting time to be at the School of Public Health. Various causes have been mentioned as possible reasons for these higher rates of incidence and mortality and hospitalization in our communities of color. Some of these pertain to a lack of access to health care and health insurance that results in a higher prevalence of less well-controlled chronic diseases. We know that persons with severe comorbidities are more likely to die, and that likely does contribute to this because obesity, hypertension, diabetes, chronic obstructive pulmonary disease are more common in persons of color and lead to higher risks of death. We also suspect that there are certain non-medical threats to health that are more prevalent in our communities of color. These include food and housing insecurity and exposure to toxic environmental exposures that heighten the risk of mortality from this infection. We also have evidence that persons of color are more likely to engage in riskier occupations, including providing care at long-term care facilities, which of course have been an important focus of disease. And we also know that persons of color are more likely to get care in safety net facilities that may be somewhat understaffed and easily overwhelmed by COVID-related surges in demand for acute care among these patients. I'd like to turn now to an issue that our understanding has evolved somewhat since the beginning, and that is the issue of how COVID-19 is transmitted. Early in the pandemic, we had the sense that two main types of transmission were most operative. These included so-called droplet transmission, and I'll explain that more in a few minutes on some subsequent slides. And fomite transmission was thought to be preeminent, a preeminent mode of transmission. Fomite transmission is the kind where an environmental surface might be contaminated with respiratory secretions from a COVID-infected person's, say a subway strap or an L strap or an elevator button. And a lot of our early prevention was really focused on sort of cleaning surfaces, and people were even using bleach cloths on their arriving mail and all of that. And I think over time, although we realize that that kind of transmission can occur and may contribute somewhat to COVID incidence, that it's really a minor contribution. And instead, we now think that there's growing evidence that these droplets, which are large droplets, and smaller aerosol transmission, are playing a more important role in this disease. And I'll explain that more carefully on the subsequent slides. So what do I mean by small droplets and heavy droplets? Well, this is a cartoon that sort of shows this understanding of how respiratory infections are transmitted. A lot of them are so-called droplet transmission. And these are, this is a person sneezing, and as a result of that sneeze, a lot of different size particles are ejected at the time of the sneeze. Some of these are very heavy and contain multiple viruses within them. They're surrounded by moisture, and because they're heavy, they fall quickly to the ground, perhaps within 3 to 6 feet. And you've all heard that rule about staying at least 6 feet apart. It's really this kind of transmission that leads us to create a public health advisory to ensure that people are distanced at least 6 feet apart. But as time has passed in this epidemic, we realize that these smaller droplets, where the outside moisture coat has evaporated off, these can drift along in air currents and reach people at further distances than 1 or 2 meters, all the way out to 10 meters in this cartoon. And we realize that there are many infectious diseases that are spread through this kind of droplet nuclei, and these tend to be more transmissible. For example, measles and chickenpox are transmitted through small floaty droplet nuclei, or so-called aerosolized transmission. We're not exactly sure what the balance is for COVID-19 between heavy droplet and smaller aerosols as a mode of transmission. But over time, one would have to say that we've begun to suspect and to develop a sense that these kinds of aerosols are important in the transmission of this disease. A lot of our feeling about this 6-foot distance came from studies back in the World War II era, where photographs were taken of people sneezing, and you can literally see some of these large droplets coming out, these heavy droplets that will fall quickly. But really, some of our understanding of this was limited by the imaging technologies available at that time. And if we look at more recent studies of long-range video imaging, we now realize that when someone sneezes, it's a lot more than just the plume that you saw in the previous picture, that these particles can go out to 7 and 8 meters, that many of them are variable in size, and some of them are these smaller droplet nuclei that can remain suspended in the air. So that's led to this sense of growing evidence that small aerosols are important in transmission. We now believe that droplets are, of course, still important in coughing and sneezing, but that these smaller aerosols may be important in other activities like talking. And we also are beginning to appreciate the very important role that contextual factors play in transmission. We know that indoor environments are riskier than outdoor environments. One Japanese study estimated that when you move indoors, there's an 18-fold increase in risk of COVID acquisition compared to outdoor activities. And of course, within indoor environments or built environments, there is highly variable ventilation that also will affect risk. Much of what we've learned has been learned through sort of so-called experiments in nature, cluster investigations, including the infamous choir practice where one symptomatic person transmitted COVID to 32 choir members, even those who were not within 6 feet of them, but sort of distantly present in the room. We've also studied clusters in fitness gyms, boxing matches, call centers, churchings, and the common feature of these clusters is that the index person who was infected engaged in singing or panting or talking loudly. Nonetheless, we do believe distance is still important. One author that I read recently talked about an analogy to smoke, where if you are in a room with a smoker, of course, if you're standing close to the smoker, you'll be more annoyed and affected by the smoke. But if you are distant in the room, you'll be less annoyed. But if ventilation in that room is poor, that room becomes the so-called smoke-filled room and may in fact carry a risk even in the distant parts of that room. Is this gospel at this point? Is this dogma? No, there's still controversy about this controversy between small aerosol and large aerosol transmission. And in fact, just this past week, the CDC posted a new guidance that acknowledged the importance of small aerosols, and then 4 days later or 3 days later took that guidance down. In fact, here it is. On Friday, September 18th, the CDC website said, there is growing evidence that droplets and airborne particles can remain suspended in the air and breathed in by others and travel distances beyond 6 feet. For example, during choir practice, in restaurants, or in fitness classes. And they went on to say, this is thought to be the main way the virus spreads. On Monday, they changed the guidance back to the old guidance that said that virus is spread mainly from person to person and does not mention the possibility of it being airborne. The WHO has acknowledged increasing evidence about airborne transmission. They did so in July, but they have maintained their stance that the virus is still mainly spread by large droplets that are emitted through coughs and sneezes. So I think we have to continue to watch this. There'll be further study of this issue, but overall, I think there's been a shift in our understanding of this issue. So another thing where we've seen a big shift in our perception of the efficacy of a prevention mechanism is in the area of facial masking. You'll recall that at first in the US epidemic, US recommendations did not include the recommendation for facial masking. But as the weeks went by and we observed them being used successfully in China and other Asian countries, we began to revise our opinion of this in response to accumulating science that has suggested that these masks were valuable for so-called source control. The other thing we started learning about COVID was that importantly for this virus, a lot of transmission events relate to transmission from people without symptoms, asymptomatic persons, or persons who are pre-symptomatic during the incubation period of COVID-19. The reality is that we estimate that about 40% of the time that asymptomatic infection occurs, about 40% of the time, and that among these asymptomatically infected people, viral shedding is equivalent to that observed in symptomatic persons. That reality led to the recognition of that reality led to the adoption of universal facial masking as a way of interrupting symptomatic transmission. There has been further contributions to the thought about why masking may help beyond the idea of source control, the idea that an infected person, because we don't know who might be asymptomatic and infected, that it makes sense for us all to universally mask to protect our communities. Well, there's maybe additional reasons to wear masks. Although source control is thought to be the major role of facial masking, there is evidence in the science that that masking not only protects, that wearing a mask if you are uninfected has some protection or prevention benefit for the mask wearer, so that
Oh, Dr. Hirschau, you muted by accident or somehow. There we go.
Yeah, sorry. So that has in part of this understanding has led to a recent hypothesis that has emerged that's called the variolation hypothesis. It was a recent New England Journal article or piece in the New England Journal written by George Rutherford and Monica Gandy. And it's a very interesting hypothesis. First of all, what is variolation? Variolation was a smallpox prevention strategy that was practiced in the colonial era. In fact, Cotton Mather made his medical reputation by promoting variolation in colonial Massachusetts. Of course, he went on to infamy in the context of the Salem witch trials, but he was, in that stage of his career, he was very much a physician and promoted this idea of variolation. Variolization involved taking smallpox material from open pocked lesions from smallpox cases and using small amounts to inoculate other people in the community, with the idea of a small amount of inoculum would be actually helpful and promote protection against smallpox. And it worked. Variolation was affected. The only problem with variolation was that it ended up killing the patient in 2 to 4% of cases. And when Jenner developed the cowpox vaccine, which was much better tolerated and safer, it completely supplanted this old medical orthodoxy surrounding variolation. But nonetheless, there's this deeply ingrained notion in infectious diseases that, that a high dose of an infectious pathogen can overwhelm host defenses and lead to more severe outcomes of any infectious disease, whether it's smallpox or in this case, COVID. The suspicion is perhaps that a high initial inoculum or number of viruses infecting somebody can overwhelm and dysregulate the immune system. And masking, when it's worn by people who are uninfected, may in fact reduce the inoculum size. So if a mask-wearing person acquires infection, they will do so with a smaller dose, if you will, of virus, and that could lead to a lower severity of illness than if you acquire disease without a mask in place. It's an interesting hypothesis. Is there any evidence for it? Well, there is actually an animal model. Who knew? The Syrian hamster simulates mask wearing. And what has been found in animal model studies is that hamsters that are masked and exposed to infectious inoculum are likely to have milder disease than non-mask wearing hamsters. There have also been some experiments in nature. There was an Argentinian cruise ship outbreak where passengers were provided with surgical masks and required to wear them, so adherence was thought to be very good. In that context, the rate of asymptomatic infection among people who acquired disease on that cruise ship was 81%, much higher than that 40% that we estimate for overall COVID asymptomatic infection rates, and much higher than the previous cruise ship outbreaks that had been worked up that suggested 20% asymptomatic infection. We've also studied outbreaks in food processing plants, and in one of those studies, more than 500 people became infected, but they had been issued masks, and in that outbreak, 95% were asymptomatic. So coupled with that is the observation that even asymptomatic persons that is acquire asymptomatic infection undergo an induction of strong cell-mediated immunity that offers protection. So the idea is that masks can be a bridge to vaccines and allow some of us who don't avoid acquiring infection. It may lead to a greater likelihood of mild or asymptomatic infection, and may be a more painless way of getting our society moving toward herd immunity. Studies are clearly needed to inform this hypothesis, but it is an intriguing idea that masks may not only function as source control, but be beneficial for uninfected persons as well. It's quite unfortunate that basic and proven prevention modalities like mask wearing have been politicized, and the emergence of an anti-mask mask wearing group may pinpoint one of the most important reasons that the US may be doing worse in our battle against COVID than other countries. That is the notion that Americans see a conflict between public health and private liberty, and simply often don't like to be told what to do. In the end, there seems often to be no clear sense that we are engaged in a common struggle, and no clear consensus on what we are willing to sacrifice for each other in that struggle. Thought I should move to a more promising area and a more hopeful area. We are now getting close, I think, to getting some exciting data in the ongoing phase 3 vaccine trials that are going on. There are several in the field right now, including the testing of the Moderna platform vaccine at UIC. We are the sites of one of the sites of that clinical trial. But in the background of all these trials, there is growing public concern that political pressure could lead to the premature approval of vaccines. And that led some of the three companies that are developing these vaccines to release their protocols, that is their vaccine trial protocols, so that they could be completely transparent to the public about the rigorous science that was being used in these vaccine trials. There is evidence, though, that the public is moving away toward vaccine hesitancy, away from vaccine acceptance. A Pew Research survey in May showed that 72% of Americans would be willing to receive available vaccine. By September, that figure had decreased to 51%. And very ominously, 3/4 of those surveyed said that they thought the US would approve a vaccine before safety and efficacy were established. I think some of that skepticism was based on the EUAs that had been issued by the emergency use authorizations that had been issued for other products pertaining to COVID. Most notably the EUA that was issued for hydroxychloroquine and then later for convalescent plasma, the latter before there was clinical trial data supporting its efficacy. I also think that the framing of the vaccine development as occurring at warp speed was unfortunate and has led to a sense of this moving along at a rushed pace and perhaps outdistancing the science behind it. I think another issue is that although when the companies released those plans about their protocols, they were generally viewed as very rigorous and standard, but there was one element in the Pfizer vaccine clinical trial that did attract some attention, and that was the fact that the protocol gave allowance for the early evaluation of results after just 32 infection events had occurred. And although the efficacy might be measurable at that point, safety and duration of protection cannot be measured. And I think what we can anticipate is as these EUAs are are determined as vaccines are developed and then released for use, that we can anticipate, I think, that there will be public hearings to again lend a degree of transparency to allowing the public to peruse themselves or review themselves the science that's backing these EUA determinations. There's also been concern about adverse events. There were media reports of transverse myelitis in the AstraZeneca trial. There was one report, and that was reported by the media, not by the company. And as yet, AstraZeneca has really released no data on the participant's condition or the receipt of placebo versus vaccine. And then in subsequent developments, AstraZeneca admitted to a second earlier case with symptoms of transverse myelitis, but they said that they had not felt that was relevant because that person was subsequently diagnosed with multiple sclerosis, and that was an alternative explanation rather than vaccine exposure. In any event, there's this tension between a need to maintain confidentiality in these trials and not release data, and a perceived lack of transparency. And I think we can anticipate in the post-licensure era that it'll be very important to monitor vaccine safety as we move forward with these products. There is other things that I think are really interesting to think about and consider are how the vaccine will roll out in the early stages when we are in a vaccine shortage circumstance. And the National Academy of Medicine has been asked to form a committee to advise the Immune Practices Advisory Committee on a sensible strategy for rollout of vaccine in the era of scarcity in the immediate earliest stages of vaccine rollout. Various strategies have been offered as potential approaches. One is to prioritize the persons most at risk, our healthcare workers, nursing home residents, prison inmates and workers at prisons, persons with underlying health conditions, and people from communities of color. An alternative strategy would be to prioritize reducing transmission by prioritizing the public workforce, essential workers, students, and young people who may be more likely to spread infection to others. So we'll have to keep our eyes on that, and I think that's something where we may all want to raise our voices in favor of different strategies during this era of shortage. So as long as I mentioned young people and the need to protect them, I thought I would end with some comments about COVID on college campuses, because I've been very involved in trying to come up and develop plans to keep the UIC campus safe. And a lot of the best data on this comes from a New York Times survey of more than 1,600 colleges. And as of September 25th, that report noted that there had been 130,000 cases linked to college campuses and fully 70 deaths since the pandemic had begun. There were 35 colleges that had over 1,000 cases, including University of Illinois at Urbana-Champaign. At UIC, we're faring better. So let me turn to the planning that we did on COVID. This is just a map. The darker colors on this map are the universities that are more burdened by COVID, that have more than 1,000 or more cases. The lighter colored dots are lesser levels of campus involvement. So this summer, I and a bunch of other faculty met to discuss the reopening of UIC's campus and to consider plans for that. We came up with many, it was a complicated reopening plan, but at its heart, there was a social compact that was to promote a prevention ethos on campus. That is to say that citizens of the UIC campus should see it as a civic responsibility to protect the UIC community through careful adherence to basic infection control measures like social distancing, avoiding crowds, liberal use of hand hygiene, and of course, universal face masking is very important. Part of that effort involved starting what we call the surveillance testing program, which involves testing asymptomatic persons with a saliva-based platform repeatedly and periodically over time. We are building capacity in this program, and currently we're testing about 500 to 600 persons a day, which is not enough to weekly test our 18,000 UIC citizens. So we hope to build to that capacity in the ensuing weeks and months. But we have focused our early efforts on those populations that we deem at particularly high risk. That includes our dormitory students that number 1,400, our athletes, and our performing arts students. And it isn't just enough to identify and isolate persons with infection. Early on, we envisioned a role for contact tracing in this effort. What other universities, including Champaign-Urbana, have done is they have relied on local health departments to do their contact tracing. We chose a different path, and that was to hire, to start a program of contact tracing internal to UIC that we've called the UIC COVID Contact Tracing and Epidemiology Program. I've had the good sense to hire some of our alums to head this program. Ellen Stein, a former MS student of mine, and Jocelyn Vorn, also a former MS student of mine, are the directors of this program. And thus far, we've hired 17 of our students to engage in contact tracing. These are heavily weighted towards School of Public Health students, not surprisingly, but they also contain representatives from other colleges on campus, including the College of Nursing, the Anthropology program, the College of Social Work, and the College of Applied Health Sciences, with an occupational therapist from that program. We also have hired some of our undergraduate public health majors to help in this effort as well. The idea is these students are sort of indigenous workers. They understand the attitudes of students. They're able to establish trust with students. And so far, I have to say the results have been quite remarkable and good. We have been in operation just since August 31st, so really just 1 month of operation. But even in that time, we've revealed several clusters and we've linked them to small social gatherings, mainly in off-campus locations. And we've thus far, this is slightly old data. At this point, when I made this slide, we had done about 13,000 of these saliva tests through our surveillance testing program, identifying 69 infected persons for an overall positivity rate of 0.52%. We now had a surge in cases last week, so this number is more up to 0.9% or so, and we have identified one dormitory-based cluster, and we are stepping up testing in the affected dormitory to see if we have successfully contained this or whether there'll be other generations of cases moving out from this cluster. When we find infected persons and their contacts, we either isolate or quarantine them to eliminate the risk of forward transmission of infection. Our contact tracers mainly contact trace, of course, but they also are envisioned to eventually play a health ambassador role, which will involve engaging with students and employees on prevention messaging, facilitating certain health activities like flu vaccination and hopefully later COVID-19 vaccination, and engage in observational studies to check out how well our community is adhering. We envision stationing workers or our student workers in high traffic areas on campus to do observational studies to gauge, for example, how well people are adhering to mask wearing on the campus. Well, that about ends my formal remarks. I wanted to leave some time for questions. I thank you for your attention, and I guess we're open to questions now.
Well, thank you, Dr. Hershaw. This has been incredibly informative and interesting. We do have several questions that have come in, and encourage our participants, if they'd like to ask questions, to put them in the chat feature. Let me start with the first question that came in, which was, what do you think of the move to open more indoor venues in Chicago starting tomorrow?
You know, I have to admit that I haven't read that guidance yet. I think, I think if it's done cautiously, we have this more nuanced view of risk now. And when you move into indoor settings, if you can ensure good ventilation and mask wearing within those facilities, we believe that those kinds of reopenings can occur safely. But again, there has to be buy-in for things that have been somewhat controversial, like mask wearing. I think we'll have to do that kind of reopening cautiously and carefully monitor whether, in fact, we see any rebound in case occurrence concurrent with those kinds of reopenings. But I think basically we're at a point now where in Chicago, where there is a fair amount of community transmission still going on. So I think we have to be cautious about that kind of reopening.
Yeah, thank you for your thoughts on that. Another question that came in is, do you have any thoughts on how the deaths are recorded for COVID? The person says they've seen many social media posts saying that the deaths are inflated, but they're skeptical of how low those numbers are.
Yeah, I mean, my sense of death reporting is that it's deflated, and that there is this monitoring of excess death rates. So, in other words, we see some people, we see an excess of people dying from non-COVID related causes. So, if we compare 2020 to 2019, we see that there is an enhancement of excess deaths that haven't been characterized as due to COVID. And we believe that many of these excess deaths are in fact undiagnosed cases of COVID. We've also heard reports of people who may not have the ability and the mobility to access prevention and treatment, dying at home without being able to avail themselves of services. And of course, all of these issues are exacerbated and more prominent in our most vulnerable populations, the elderly, and as I made a case earlier in the talk, in our communities of color.
And are you speaking specifically about the United States?
Yeah, I tend to mostly focus on the United States because I guess it's what I know best.
No, of course, that makes sense. I just wanted to clarify. Great. So next question is, the person asked, do we really believe that someone needs to remain in quarantine for a full 14 days after the last known contact if they have no symptoms and a negative test? And then they go on to say, do we actually think someone who is negative on day 3 might turn positive on day 13?
It's possible. I think the quarantine period of 14 days is built on our understanding of the biology of the organism and the biology of infection with COVID-19. It's really built on the issue of incubation period, and we with COVID, we have a disease that has about a 1 to a 14-day incubation period. So that's why that 14-day period is hardwired into the recommendations. And it is true that the bulk of people with COVID will emerge with symptoms on days 5 through 9 after the infection event, and late emergence of symptoms is somewhat unusual, but not unheard of. So maintaining isolation for the full 14 days, I would still advise strong adherence to that recommendation.
Thank you for that clarification. Next question. What is good ventilation, and what are the prevailing expert opinions about safety of air travel?
I will have to defer to my environmental and occupational health science colleagues on the ventilation question. The basics of it are lots of air exchanges, ideally exhausting air to the outside environment, and sort of replenishing the air in the room with fresh air. The simplest form of ventilation that can be quite effective is to open windows. But in Chicago, that's perhaps a time-limited thing that we can do in the face of our weather here in Chicago. So I think that's what I would say about the question of environmental. What was the second half of the question? I'm sort of lost track there.
And just what are the prevailing expert opinions about the safety of air travel, which I think you.
Oh, yeah. I mean, my sense is that most people would rate air travel a high-risk endeavor. It is interesting that we're not hearing that many reports, though, of outbreaks, airline-related outbreaks. But partially that may be because people are abstaining, planes are largely empty, allowing distancing to ensue. I think, occasionally passengers who think they have a half-empty flight have been blindsided when they land in an airport and a group of passengers are loaded on that they didn't anticipate would be part of their flight. So I think most experts would opine that air travel is still hazardous.
Okay, thank you.
The risk can be, again, mitigated by wearing masks and so forth.
Which I think many of the airlines now require
and good hand hygiene and all those other things.
This is a two-part question. How do you anticipate flu season will complicate COVID response and potentially overwhelm the health systems due to the similarity of symptoms?
That's a really, not that all the other questions weren't good questions, but that's something I've been thinking a lot about lately. So I really like that question. What we're doing right now is, a lot of contact tracing. And there's this category that we deal with in the contact tracing that we call PUI, which is persons under investigation. And these are people who develop respiratory symptoms but haven't yet been tested for COVID. But in this era, we have to presume that their respiratory symptoms might be due to COVID. So we take very serious precautions with those people and keep them in isolation generally until their test comes back negative. And in some circumstances where their symptoms are so convincing for COVID, we'll keep them in isolation even if their test comes back negative, knowing that there are false negative tests with any COVID case. And this just sounds too risky to allow them to, exit isolation. So in terms of the flu season, so what will happen as the respiratory virus season starts is that right now, people with respiratory symptoms are at a low ebb. We can keep up with it. We can sort of really focus a lot of energy on these persons under investigation, isolate them if they're dormitory students and so forth. But when these symptoms start becoming more prevalent and more common as the winter takes hold and the cold weather takes hold and people move into indoor environments, we anticipate that they may well overwhelm our capacity for the testing of these individuals, for the isolation of these individuals, and we're now trying to think very hard about increasing our capacity. There's also some evidence that co-infection can occur. So if you acquire influenza and COVID at the roughly same period of time, that the outcomes of that kind of co-infection situation will cause more severe disease than a single infection with COVID would cause. So that's another issue, but perhaps less common and less important overall as an issue. So I think we know that our testing sites have been challenged at times. And I think as more people develop respiratory symptoms, it may well overwhelm our testing capacity. So, and frankly, our testing capacity still needs to be built up and increased to prepare for this increased demand in testing that will occur along with the flu season.
Thank you. I know the flu is on many people's mind, and just as we're in that season, so that's really helpful to hear perspective. We only have a few more minutes, but we have two really good questions. So I'm going to try and fit them both in if you don't mind. The first one is, has there been an uptick in cases after recent protests and group demonstrations?
Um, Surprisingly, not so much. There, uh, there, and I think partially that is because at some of these protests, people were good about wearing masks and things like that, and within the constraints of marching, they were trying to distance within that context. But most importantly, these demonstrations were outside, and you really can't adequately say how protective outdoor environments are. There's a huge dilutional effect, and when you're outdoors, and if you sneeze or cough, that ambient air will quickly dissipate and lower the concentration of virus to a state that is probably protective to some extent. So I think it's a combination of all of these things that has mitigated the risk at these demonstrations. It's a little hard to sometimes determine exactly what the impact of those are, but we really didn't, in most jurisdictions, we didn't see a surge in case occurrences in the aftermath of the George Floyd and Breonna Taylor demonstrations and other demonstrations that have happened as well.
Thank you. It will be interesting to see how much Chicagoans can endure being outside in the winter. Just using your example of how outdoor is a better place to be.
I guess I should mention closer to home the Kenosha demonstrations.
Yeah. Oh, yes. So last question for you. Can you please summarize what we know about how long people have immunity after they are infected?
Yeah, that is, I can summarize that pretty quickly because we don't know a lot yet. That's one of the $64,000 questions, is the duration of protection after natural infection, and the duration of protection after vaccine immunity will also be a huge question that we have to answer. And that's why there's this fear that by rushing the clinical trials to the point where we don't really have long-term follow-up information, we will eliminate our ability to gauge vaccine immunity and its persistence and durability over time. We've only been dealing with this virus for about 9 months. We have a lot to learn about it, and that includes duration of protection. The current CDC recommendations are that protection is thought to be good enough for 90 days after a bout of COVID that you don't have to re-isolate somebody who's exposed to COVID. Let's say you have COVID January 1st, and then sometime in March you get exposed again. If it's within that 90-day window, we believe that your COVID infection from January will confer meaningful protection for you, and that you would not have to re-isolate at that time. But there's a reluctance to go beyond the 90-day period and postulate at all about the duration or durability of immunity. At this point, we really have to learn more about that. And we have heard isolated reports of reinfection. In general, those reinfections tend to be mildly symptomatic, though, as if there may be some hangover protection for those reinfection events.
Thank you. Thank you for this incredible discussion. It's been incredibly fascinating. And as you just pointed out, it's been 9 months since there's been so much work and research. So thank you for all of your time and your talent, and certainly all the research and work you are doing to help us fight this battle with COVID-19. We're so grateful that you are on faculty, and I'm grateful that you've hired alumni to also start the program with you. And so thank you for everything you're doing. It's been really a great discussion.
Well, yeah. Yeah, we've actually hired current students and alumni. So, I think part of the contact tracing, the wonderfulness of it, is that it has made many students who are involved feel connected in a way that's difficult to feel connected in this era when we're all learning at a distance and so forth. So that's been sort of a collateral benefit, you would say, of contact tracing program, of the contact tracing program.
Well, thank you again. Thank you for all your time this afternoon and sharing this wonderful presentation with us. Just to wrap up quickly, please join us on Wednesday, October 14th at noon Central Standard Time for our next Alumni Exchange program featuring UIC alumna Melinda Matrovia and Greg Sipley, who are two active Toastmasters that will teach us the tools we need for the confidence and poise when speaking in the moment as they present an interactive discussion on learning to master impromptu speaking. As always, you can find more information at go.uic.edu/alumni exchange, including the slides from this program and the video recording. And of course, please be on the lookout for our survey afterwards. Thank you again, Dr. Hirschau, for sharing your knowledge and all this time. We really are very grateful to you. Thank you to all of you for joining us, and we look forward to seeing you in a future UIC Alumni Exchange program. Thanks so much and have a great rest of your day.
Thank you.